Assalamu alaikum. My name is Dr. Enan Arshad and I'm working as assistant professor at Aga Khan University Hospital, Karachi. And I'm also secretary of Pakistan Society of Internal Medicine, Karachi chapter. I welcome all of you to this very important course, Hypertension course. And before starting this course, I would like to tell about the last session that we have taken in that course. So the last session was the chairperson was Professor Hafiz Chaudhry, and there were talks on secondary hypertension, which was the non-renal part, and the renal part will be discussed somewhere else. And another that was presented by Professor Imran Hassan Khan. And the second talk was resistant and pseudo-resistant hypertension, and it was given by Professor Mibg Scan. So it was a very informative session, and we really enjoyed that. In today's session, we are very fortunate to have Professor A.H. Amir with us, and who is a chair of this session. And I would like to introduce him. So Professor A.H. Amir is basically he is MBBS, MRCP UK, FRCP Edinburgh, and FACE US. He is also having CCST in diabetes, endocrinology, and internal medicine. He's in charge and head of services department of diabetes, endocrinology, and metabolic disease at Khyber Girls Medical College, Hayatabad Medical College Complex, Peshawar, Pakistan. And he's immediate past president of Pakistan Association of Clinical Endocrinologists in Pakistan. He's past president Pakistan Endocrine Society, vice president South Asian Federation of Endocrine Societies, chairman Task Force Diabetes Executive Committee KPK. He's also executive member of National Task Force for Diabetes. He's convener of CPSP Endocrinology Pakistan, and project director extension DTOC and Insulin for Life project, government of KP. He's also member of fellow of American College of Endocrinology Recommendation Committee for AACE and course director of Advice Academy of Pakistan. And I welcome Professor A.H. Amir. Assalamu alaikum, sir.
Wa alaikum salam. Thank you, Anand, for a kind introduction.
So today's session, we have two talks and one talk on, so first talk will be on, low renin hypertension, and it will be given by Dr. Freddie, Henna, Shomoni, and another talk will be given by Professor Khurshid Khan on pheochromocytoma. So before starting that, Professor, our chair, please, if you want to say something.
I think we will take his comments at the end. The chair will give his concluding remarks at the end. Now okay. Call the first speaker, please. Introduce and call him for the presentation.
Okay. So I would like to introduce our first speaker, Mr. Freddie, Dr. Freddie Henna Shomoni. He's MD and Diplomat American Board of Internal Medicine and AHSCP, FRCPC. He's a clinical investigator at the US NIH Eugene Kennedy Shriver National Institute of Child Health and Human Development. His clinical and research interests are the diagnosis and management of familial endocrinopathies, endocrine hypertension disorders, iron metabolism errors. At NICHD, he is also the serving director of the Office of Education's Graduate Medical Education. He is chief of internal medicine, endocrinology, and genetics inpatient ward, and associate program director of NIH Inter-Institute's Endocrinology and Metabolism Fellowship Program. Dr. Shomoni completed his clinical training in internal medicine at the Yale New Haven Medical Center YSR program in adult endocrinology, diabetes, and metabolism at NIH, with focus on endocrine hypertension and genetic disorders under the mentorship of Dr. Christine, and in clinical biochemical genetics at the University of Toronto's Hospital for Sick Children. He's a board certified in internal medicine, endocrinology, and metabolism by American Board of Internal Medicine and Royal College of Physicians and Surgeons of Canada. and clinical hypertension by American Society of Hypertension. He is a fellow with the Royal College of Physicians and Surgeons of Canada and an active committee member of the Endocrine Society Hormone Health Network, the Eastern Europe and Middle East Regional Advisory Group for International Society of Hypertension, and the 2020 Hypertension Canada Guidelines. Dr. Shomoni has authored and co-authored over 100 research papers and book chapters and is the editor-in-chief for Endocrine and Metabolic Science. So without wasting any further time, I would request our speaker to please start presenting. Thank you, sir.
Hi, good morning, everybody. Assalamu alaikum. Hope everyone's good. Can you hear me well and see my slides?
Yes, we can hear you.
Excellent.
Thank you.
So the title of my talk is Lorena and Hypertension, and I'm very grateful for this opportunity. These are my disclosures, and the objectives of the talk is to go over what Lorena and hypertension is, with a focus on a most important subtype of Lorena and hypertension, which is primary aldosteronism. And I'll go over my personalized approach to diagnosis and treatment. So what is Lorena and hypertension? It's defined as a low plasma renin activity or direct renin concentration in a patient with hypertension. And yes, the most common cause is primary aldosteronism, which is the most common secondary cause of hypertension. So as you know, you can divide hypertension.
Sorry to intervene in between, sir. So we have this activity of giving pre-poll before starting your talk, and after that we will have the post-poll questionnaire. So may I request for the pre-poll questionnaire? Okay. So sir, please, you may continue.
All right, thank you. So good job, everybody. Everyone did very well. Going back to the talk, as you know, you could divide hypertension into biochemical phenotypes or subtypes based on the renin. So if you have a low or suppressed renin, then this can be regarded as a low renin hypertension subtype. And if the renin is normal or high, then it could be regarded as a normal or high renin subtype. And that can help you differentiate between the various secondary causes of hypertension, and the focus of this talk is the low renin subtype with a focus on primary aldosteronism. The other entity with low renin is Little syndrome or hyporeninemic hypoaldosteronism, where aldosterone and renin are both low. So the focus of this talk is on the subtype that leads to low renin and high aldosterone levels in a patient with hypertension. And how is that defined? Well, the threshold to define a low renin state is assay dependent. If you're using a plasma renin activity, then we use this cutoff. If you're using a direct renin concentration, then it's a cutoff of less than 15. Now, PRA is convenient for estimating the biological activity of the renin system, and we use a conversion of DRC from PRA to DRC of a factor of 8.4 as an alternative test. However, they correlate poorly when PRA is less than 1 nanogram per ml per hour. So make sure you know which assay you're using to define low renin state and at what threshold. Nonetheless, they could both be used. And in any patient with hypertension, knowing what the renin status is can certainly help delineate the next best step in managing this patient. So why is low renin hypertension important? Well, if you look at the African-American population, we know that hypertension is the leading modifiable risk factor for cardiovascular disease. And low renin hypertension in particular has a prevalence of 30% in patients with hypertension. And low renin hypertension may also account for the observation of elevated cardiovascular disease, resistant hypertension, stroke, left ventricular hypertrophy, and CKD. Also, individuals with low renin hypertension are less likely to have better blood pressure control despite greater awareness of hypertension. It is associated with elevated aldosterone, and elevated aldosterone that then leads to low renin has a lot of negative repercussions on the cardiovascular system, as you know. There's also unique genetics and racial disparities associated with low renin hypertension. So particularly in African-American populations, but so is true amongst other populations, low renin hypertension phenotype can lead to a catastrophe on the cardiovascular system. So here's my approach to low renin hypertension. It's a very busy slide, but I want you to know that There are a number of endocrine conditions that could lead to low renin hypertension. You can best divide your differential diagnosis of low renin hypertension based on the aldosterone. If you have an inappropriately elevated aldosterone with a low renin, then you're certainly talking about the possibility of primary aldosteronism, which can be unilateral, bilateral, or familial. If you have low renin hypertension with normal aldosterone values, then you should be thinking about the milder forms of primary aldosteronism or the non-classical apparent mineralocorticoid excess syndromes, non-classical Little syndrome, mild Cushing syndrome, or Gordon syndrome. And then the low renin, low aldosterone phenotype is a rather long list, which I will not go through. But the focus of the stock is to really, if there's one thing to remember from the stock, is that if you encounter a patient with hypertension, independent of which medications they're on or the severity of hypertension, and you check a renin, then the next best step is to check an aldosterone value. And if the aldosterone is elevated with a low renin, then you're really talking about the possibility of primary aldosteronism. And that's really your take-home point. I check aldosterone and renin on every hypertensive when I first diagnosed them with hypertension. I understand that this approach might not be feasible in community centers or in areas of the world that don't have the renin and aldosterone assays readily available, but it helps me tease out early on if I'm dealing with this very common entity called primary aldosteronism. It can also help me formulate a differential away from these other conditions that I always think about in any patient with hypertension. So what happens in an individual with low renin hypertension? Well, there's a lot of genetics involved, genetic interplay between the adrenal glands as shown here and the renal tubules. Individuals can inherit one or several genetic predispositions to enhance sodium absorption or enhanced aldosterone secretion that can then lead to the low renin hypertension phenotype. If an individual is predisposed to having these genes or pathogenic variants of these genes that lead to enhanced aldosterone secretion, then that leads to what is known as primary aldosteronism. If an individual has predisposition to enhanced sodium absorption from the kidneys, then that leads to the low renin, low aldosterone phenotype or the Little phenotype. Someone can have a combination of both of these genes, and then it becomes a tug of war between the low renin, high aldosterone phenotype and the low renin, low aldosterone phenotype. So this brings us to the most important secondary cause of hypertension, which is primary aldosteronism. Surprisingly, it's extremely common. It's a misdiagnosis in individuals with hypertension across the spectrum. So here's your second most important take-home point, is that primary aldosteronism is very common. It can exist across the spectrum of hypertension. It can be seen in individuals with mild hypertension, with moderate hypertension, and with resistant hypertension. Contrary to previous beliefs and teachings, you don't need to have resistant hypertension for primary aldosteronism to really manifest. It's truly a spectrum of disease. And in order to detect that spectrum, you've got to check renin and aldo early on in the diagnosis of hypertension. Unfortunately, guidelines miss the diagnosis of primary aldosteronism because guidelines focus on the severe end of the spectrum. So I think that's how you can distinguish yourself as an astute physician in diagnosing primary aldosteronism is by not setting barriers. Just screen and don't set barriers for yourself. Otherwise, you're going to miss this diagnosis. Hyperplasia is more common than adenoma. Approximately 80% of cases arise from bilateral disease that require medical management with mineralocorticoid receptor antagonist. Here's your other clue. Most patients have normal potassium levels. Only 20 to 30% of patients have hypokalemia. So the combination of hypokalemia and hypertension is really only seen in 25% of cases. Up to 50% have resistant hypertension, but the other 50% have mild to moderate disease. It can be seen in individuals with so-called labeled essential hypertension. And screening is typically done with an aldosterone to renin ratio. And some of us in the field are also using a 24-hour urine aldosterone, not only for confirmation, but also for screening because it's more quantitative. So 3 cardinal features for primary aldosteronism, my friends, is that you have to have suppression of baseline renin. So renin has to be low, suppressed. There's got to be inability to stimulate renin secretion normally. And 3, an inappropriate or non-suppressible aldosterone production. In other words, you have to have high aldo, low renin to define primary aldosteronism. If there's one study to know, then it's certainly this a very, very well done study published in the Annals of Internal Medicine in 2020 called The Unrecognized Prevalence of Primary Aldosteronism, highly recommended. What this study did is they screened with a 24-hour urine aldosteronism many individuals with different types of hypertension, including untreated normotension, stage 1, stage 2, and resistant. And they used a cutoff of 12 micrograms for the 24-hour urine excretion of aldosterone to define primary aldosteronism. And as you could see, even in individuals with untreated normotension, some had primary aldosteronism. Individuals with stage 1 hypertension had primary aldosteronism as well. So really, it's a spectrum across these different stages of hypertension, and it could be any one of your patients in your hypertension or internal medicine clinic that are so-called labeled with mild hypertension, but in reality, they have primary aldosteronism that would require different therapeutic strategies than your calcium channel blocker or your ACE inhibitor. Here's another representation from the same study looking at the prevalence within the subset of suppressed renin. And I want you to look at the crude prevalence of the adjusted prevalence, independent of the stage of hypertension. But in any given individual with hypertension, over 15% to 20% prevalence of primary aldosterone can be seen, and the prevalence increases as the severity of hypertension increase. So the odds of having a patient with primary aldosteronism, if they had resistant hypertension, can be flip of a coin. And this is very, very significant and important to not miss this diagnosis. So how does that translate to numbers? Well, if 70 to 100 million adults in the US have hypertension, then 10% prevalence of PA would lead to 7 to 10 million adults with primary aldosteronism. These are conservative estimates for resistant hypertension is 5%. Conservative estimates for resistant hypertension and primary aldosteronism is 20%. So 33% of patients with PA have unilateral hypertension of aldosteronism. We're talking about very high number of individuals with PA that go undiagnosed every year in the United States. And this data is also replicable in other parts of the world. How are we doing with screening? Well, we're doing very poorly. So this study published in Hypertension in 2020 looked at screening rates for primary aldosteronism in individuals meeting criteria. And guess what? Only 2% of individuals that met criteria for primary aldosteronism underwent screening, which suggests that we're missing so many individuals in the community from being screened and from benefiting from treatment focused on primary aldosteronism. So this is another representation of the spectrum of primary aldosteronism, and think of it as a continuum. It starts in individuals with normotension, and then it can be seen in later stages of hypertension. And the current threshold set to screen for PA will miss the normotension to early stages of primary aldosteronism, unfortunately. So guidelines need to be revised to be inclusive of this spectrum of primary aldosteronism, and there's a lot of data coming out that will support this approach in the future. We know that primary aldosteronism is a genetic disease. Most individuals have somatic mutations in different channels, and it's ethnicity specific. So for example, African Americans have higher calcium channel somatic drivers as opposed to Caucasians having higher rates of KCNJ5 or potassium channels. These are the sort of somatic mutations leading to aldosterone-producing adenomas. But there are also germline mutations that could lead to familial causes, and there are a number of familial causes, which I will not go through, but you should suspect a germline mutation or a familial primary aldosteronism in any young individual less than 35 years of age presenting with primary aldosteronism, or if there's significant family history of PA. Interesting new data suggests that after you've established the diagnosis and you've taken your patient for adrenalectomy, if the adrenal vein sampling lateralized, then there is a 15 to 20% risk of adrenal insufficiency in the contralateral adrenal from central adrenal insufficiency that occurs due to co-secretion of various glucocorticoids by the adenoma or the hyperplasia. So now it's become standard that everyone undergoing unilateral adrenalectomy undergoes a post-operative ACTH stimulation test in individuals with unilateral adrenalectomy to try to tease out whether this individual is part of the 15 to 20% of patients that have adrenal insufficiency in the post-op period. So this is the 2020 European Society of Hypertension guidelines that shows that it is no longer recommended for individuals with obstructive sleep apnea or obesity to undergo screening for PA. As you know, the 2016 Endocrine Society guidelines advocates for screening. However, this is an evolving science. What's interesting in these guidelines is they've added atrial fibrillation. So it's become common practice for us to screen individuals with lone atrial fibrillation for primary aldosteronism. And other recommendations to screen for primary aldosteronism includes resistant hypertension, hypertension at a young age, hypertension and hypokalemia, hypertension and adrenal incidentoma, and family history of PA or early stroke. However, in my practice, and because I don't want to miss PA, I screen every hypertensive with renin and aldosterone values. I recognize that this is not a feasible approach for everybody, but I've detected so many cases with this approach. So if you run a specialized hypertension clinic, do consider tailoring your approach so you would not miss this important diagnosis. This is a study that concluded that obstructive sleep apnea is common in individuals with and without PA, hence the European guidelines recommending against screening for PA in individuals with obstructive sleep apnea. And again, this is an evolving science and things may change down the road, but it's common practice now to not screen individuals with obstructive sleep apnea for primary aldosteronism. So here's another take-home point. As I mentioned earlier, we're only screening individuals under this blue box, and there's tons of individuals with PA that are not being screened because they're milder cases. And I think it's important for us to consider this as part of a greater spectrum and to screen for PA and not miss PA, particularly the milder form of disease. So in closing, I want to show you this important flow chart from a 2020 review in the Journal of Clinical Endocrinology and Metabolism that highlights a simplified pathway for, a simplified and an enhanced diagnostic pathway for not missing cases with mild PA. So the screening indications have not changed. However, after getting a renin, a low renin and an elevated aldo, if you have an aldo in the 5 to 15 nanogram per DL range, which is considered a mild range, then you should really consider diagnosing individuals with mild primary aldosteronism and refer them to a specialist. So this didn't exist in prior reviews or guidelines, and there's a push from the some endocrine community members that specialize in hypertension to really try to tease out milder forms of PA based on this aldosterone threshold. Otherwise, if you have an aldosterone over 15 nanogram per DL, then to proceed with the pathway that that currently exist in guidelines. And you can certainly exclude disease if your aldosterone is less than 5, independent of renin. So this new addition of the enhanced diagnostic pathway will add a lot more cases to your clinic if you were to follow those thresholds. And the treatment of choice for milder cases is mineralocorticoid receptor antagonist. You could also use amiloride or amlodipine as add-on therapy. So I leave you with this quote: almost any aldosterone level in the setting of renin suppression could represent a phenotype of primary aldosteronism syndrome that may be responsive to mineralocorticoid receptor antagonist, and that we should really have a very open-minded approach when examining a patient with low renin hypertension, and always look at the aldosterone in relation to renin to try to tease out this important diagnosis, because the therapy is different than individuals with essential hypertension. So in conclusion, my friends, low renin hypertension is prevalent, the most common cause of which is primary aldosteronism, which represents a spectrum of disease. Hyperplasia is more common than APA, and we should really prioritize mineralocorticoid receptor antagonists in these individuals. You could also add amiloride or calcium channel blockers as either monotherapy or add-ons. And I really hope that you will consider this disease in every hypertensive that walks into your clinic, if feasible. So thanks so much, and I look forward to your questions.
Thank you so much, Dr. Freddie, for a very, very informative talk. And before taking questions, we would like to have our post-test poll, so that we can see what we have learned from this presentation. So can we have a poll, please? Thank you.
All right, I think we're done with the polls. Dr. Freddie, thank you very much for a wonderful presentation. And correct me if I heard wrong. You said every patient with hypertension should be screened for serum renin level, irrespective of whatever he is taking. Oh no, the poll is still running. Sorry.
It was the last question, sir. You may continue, please.
Okay. No, let me complete this and then we ask the question.
It's done. The
Okay,
polls are done.
So you said irrespective of whatever patient is taking for hypertension, you should go for the renin level. But I understand many drugs and many lifestyle changes, they can affect your renin. Shouldn't patient be off any antihypertensive before you screen for renin and aldosterone?
Right, great question. And obviously this approach of mass screening requires validation through studies to see if it's feasible. But I do it in my clinic because that's sort of that's my research approach and also my clinical approach. So, it's if it works for your specialty and for your center and for your circumstances, that's great. So going back to the question, absolutely, there are a number of drugs that can influence the renin and the aldo ratio. However, I don't stop any medications. In fact, if someone is on an ACE or an ARB as an example, and they have low renin, then I know that's abnormal, because an ACE or an ARB should raise renin levels. So if you have a low renin state in an individual taking ACE or ARB, that may suggest that there's mineralocorticoid excess or primary aldosteronism that's suppressing the renin. I can give you other scenarios. If someone has low renin on a mineralocorticoid receptor antagonist, such as aldactone, that's another abnormal scenario, because you would expect renin to be elevated in these individuals. So I use medications to help me increase my pretest probability. And only when I have an unequivocal result, then I would stop them for 2 weeks or 4 weeks and then retest. It's also very important to know that we should not be creating barriers for our patients. We should take this opportunity at diagnosis, independent of which medications they're on. And then we could use our pathophysiology to interpret the ratios in the context of these medications. If we're going to create barriers for our patients by stopping medications and restarting and all that stuff, it might create delays in diagnosis. So the Endocrine Society guidelines from 2016 recommends against stopping any medication to prevent in creating barriers for our patients. However, I also understand that we may sometimes require to stop certain medications if the results are iffy. So you're absolutely right. We should be very careful But my approach is to just screen and then worry about it later.
And the example you gave, if somebody had low renin to begin with, but was taking ACE inhibitors or ARBs, and that was elevating his renin. So originally, low renin would be missed then.
Yes. So then you would be faced with a false negative result.
Yeah, that's right. Okay, thank you.
Thank you.
I'll take an opportunity. This is Dr. Amer from north of Pakistan. So thank you very much for excellent talk, Freddie. And in fact, it was made very, easy, understandable for our physicians. So the quick question: you're doing it in a mass screening. You said you do screen each one of your patients. Now, have you seen any difference in different ethnicity? I'm sure US has got a lot of ethnic population living in the same area. Have you seen any difference? Practically your experience. And the second question is, your second last slide was very interesting, but I couldn't see it. Would you mind emailing it to me or send me or to the somebody, because that sounds very interesting, that slide, but I couldn't see it.
We can see it right now.
Second last slide was interesting.
Absolutely. Thank you. So Professor Amir, good to see you. Hope you're well.
Thank you.
So yes, so we have a special interest in studying primary aldosteronism in the African American population, and yes, there are higher rates of primary aldosteronism in this population, likely because of inherent genetic risks that lead to increased aldosterone secretion for sodium preservation. However, primary aldosteronism has not been systematically studied in different ethnicities, including Pakistan and Middle East and different areas of Europe and Africa. So we could deduce that it's common across all ethnicities with certainty. There are studies suggesting that it's as common as it is in North America. However, I would like to see more rigorous studies to confirm that. But we do see high rates. This Annals of Internal Medicine paper is an excellent paper for everyone to read. And it does show that primary aldosteronism is very prevalent across the spectrum of hypertension and independent of the severity of hypertension. And if confirmed in other countries, then this calls for a call to action to really, consider primary aldosteronism as a public health issue.
Yeah, I follow up on what you said. I think it will really change the management course for most of our patients, ignoring what you are seeing and how often you are seeing, and to be validated in the rest of the world. I think that'll be very interesting. So excellent comment. Thank you.
Thank you.
Professor Freddie, this is Dr. Bilal Muhyiddin. Thank you for a lovely insight. Just a quick economic management question. What is your roughly expense of a patient workup that you do? Since you say that, this in my center, this is something common. We have our limitations. I just want to understand what kind of an economic cost burden this investigation will add, and what kind of, then we have to think from those angles.
Absolutely. It's an important question. And that's why what I alluded to earlier is that if we're going to screen patients with hypertension, it might not be feasible in certain areas of the world. Certainly is feasible for our tertiary center because of the abundance of resources. However, I'd like to think about it in this framework. If I miss a diagnosis of primary aldosteronism in someone in their 30s or 40s, and they go on with aldosterone excess for 30 years and ending up in diabetes, cardiovascular disease, CABG, stents, imagine the economic burden that will have on society. When we compare that path to early recognition, surgical cure, then that may be considered very cost effective on a population level. However, there has not been a head-to-head comparison for cost. Our cost of screening is less than $50. So to me, spending that extra $50 from my research pockets to try to save an individual from getting cardiovascular disease is worth everything I could do in medicine. So that's how I see it. But you're absolutely right. We would love to see cost economic analysis on a population level to see if this approach is feasible or not?
The reason why this question sort of pops up is because I'm also an interventionist. So you see coronary artery disease, 35-40% stenosis, you do your FFR studies, it's not significant, of course, but there's a strong family history, there is a diabetes and hypertension going on in the background. And you have a feeling that I've seen patients that, these diseases tend to progress. So might as well manage it right now before this person comes in with a stenotic kind of a thing. People have done their studies, and what they have found out is that only about 5 or 6% of these patients actually progress to that level. So basically, so as far as I understand, no hypertension guideline has yet stated that this investigation has to be done in everyone, because that will have a lot of cost burden on the health system at large. They're not even yet very clear about, do we need to do electrolytes of everyone? So, you have all these things. But of course, as far as from a tertiary care point of view, of course, these things must be done. And I'm totally with you. And $50 is, of course, no big deal, keeping in mind what you are later on, even in your basic management cost is concerned. And ultrasound sets you back further as far as that is concerned. Perfectly. Thank you for nice.
Beautiful. Thank you so much, Dr. Muhyiddin. And to add to your point, as you know, lipoprotein A was just recently recommended by the Canadian Lipid Association to be checked on every Canadian. So imagine the burden that will have on society and on the economy of checking LP(a) on everybody, where we still don't have effective therapeutics. But at the end of the day, guidelines are a consensus document by experts, and it should factor in economic cost. And I'm with you at this stage. There isn't evidence to recommend screening everybody with Aldo and Renin. And that's why I was very careful in saying that if you're in a tertiary center or if you're in a hypertension clinic, then I think it's important to consider teasing out these diagnoses, because they're common. There's prevalence data that back it up, but no economic data as of today.
Since you do this on a regular basis, have you had the chance of looking at the population COVID recovered? How's their renin levels doing? Did you get a chance to look at that aspect? COVID recovered.
After adrenalectomy?
No, the COVID, patients. Yeah. Because these days medical jargon is all about COVID. So
yes.
Did you have a chance to have a look at that angle?
Yeah,
those who have COVID recovered.
Right. Yeah. Well, I don't have data pertaining to COVID pre and post exposure, but we know that COVID does impact the renin-angiotensin system in various ways.
Our pre-test and post-test comparison is now ready to be displayed, and I will request Dr. Freddie to do comment on the results. Please, IT department, please show the results.
All right, so the question is, high dietary sodium consumption with essential hypertension will result in, and as you know, when your sodium intake increases, you're suppressing your endogenous renin and aldosterone production, and this low renin, low aldosterone, or normal renin, normal aldosterone is a biochemical phenotype seen in essential hypertension. However, if you have a low renin, high aldosterone phenotype in an individual with presumed essential hypertension, then you have to think of primary aldosteronism, because remember, primary aldosteronism can be mislabeled as essential hypertension. To quantify dietary sodium, you can do a 24-hour urine sodium, and most of you answered this right. The percentage was higher in the post-test, which means that my talk was well received. So thank you. Second question is, primary aldosterone can be responsible for resistant hypertension in up to 20% of resistant hypertension cases, in up to 30%, in up to 50%, and is an uncommon cause of resistant hypertension. Yes, and up to 20%. However, this depends on the definition of primary aldosteronism, whether you're using conservative measures of aldosterone to renin or not. Certainly 20% is an acceptable range. However, if you refer to the Annals of Internal Medicine paper, it can go up to 50% in resistant cases. So yes, I will give you this as the right answer. Question 3, which hypertensive patients do not need to be screened for primary aldosterone? You guys are absolutely right. Individuals with resistant hypertension, adrenal incidentaloma and hypertension, hypokalemia and hypertension certainly require screening. The European guidelines recommends against screening in individuals with obstructive sleep apnea. However, I still don't know what the next endocrine society guidelines will suggest pertaining to obstructive sleep apnea. Obstructive sleep apnea is a very common comorbidity in individuals with or without hypertension, and it should really not be the reason for screening for primary aldosteronism. At least in my clinic, I check every hypertensive, as I've alluded to. So, but you guys are absolutely right, and you nailed the question with 75% getting it right. Lastly, low renin with high aldosterone hypertension is best treated. You're absolutely right. A low renin, high aldo phenotype is primary aldosteronism until proven otherwise, and the most important management strategy for these individuals is starting them on either spironolactone or eplerenone, which are collectively known as mineralocorticoid receptor antagonist. An alternative medication is amiloride. You could also use combination amiloride spironolactone, amiloride calcium channel blocker, mineralocorticoid receptor antagonist, and calcium channel blocker. So you guys got this right. Thanks a lot.
Thank you. Well, Fadi, since one of your questions had that sleep apnea bit linked into it, and everyone is into it, I've always found it rather difficult to really stabilize this part of the question for the patients. Snoring and how bad a snoring is actually sleep apnea. Do you have any way of assessing how do you actually label a person really in your tertiary care clinic that this person is sleep apnea, and at which level do you label it?
Right. So there are questionnaires that we give our patients that ask them, 10 different questions, and if they score, an X number, then that increases their pretest probability for sleep apnea, and that would then require them to go for sleep testing. I always ask them if they choke at night, so that might have a high pretest probability for sleep apnea, and whether their partner wakes them up in the middle of the night because they're snoring or they're having heavy breathing. Ultimately, because we're part of a research study, we check every individual for sleep apnea with hypertension at the NIH. Also, it's important to know that there are other endocrinopathies that could cause obstructive sleep apnea, including acromegaly. It's because the excess water retention that occurs with acromegaly can lead to narrowing of the oropharynx, and that can lead to sleep apnea. So every time I hear of sleep apnea, a few endocrine conditions come to mind, including thyroid disease and acromegaly.
So Dr. Zulfikar Ahmed want to ask a question. So please, we would like to give, you can ask, please, Dr. Zulfikar Ahmed. Dr. Zulfikar, you are on mute, so you may unmute and ask a question.
I think inadvertently raised hand. Now we can proceed with the next presentation.
Okay.
Thank you, Dr. Fadi. Lovely presentation. Thank
Wonderful.
you for the answer.
That was wonderful.
Thank you, sir, for the wonderful presentation. Okay, our next speaker is Professor Khurshid Ahmed Khan, and he's MBBS from King Edward Medical University. He's MD. He is Fellow of American College of Endocrinology and Diplomat American Board of Internal Medicine and HSC. And he is also Diplomat American Board of Internal Medicine Endocrinology. He's a Professor of Medicine and Endocrinology, Head of Department Medicine and Allied, Fatma Memorial Medical and Dental College, Lahore. He is also visiting faculty at West Virginia University, USA. He's past president of Pakistan Endocrine Society. He's consultant physician at Doctors Hospital and Medical Center, an avid researcher with more than 50 publications to his credit in both national and international journals. I humbly request Professor Khurshid and most welcome you to join this session and give us a talk, please.
Thank you very much. I'm very grateful to Pakistan Society of Internal Medicine and the course director, Professor Azizur Rahman, for their invitation to let me speak on this forum. So today's my talk is going to be about pheochromocytoma. So let me share the screen with you guys.
Since you have already introduced your topic, we can run the pre-test poll while you're figuring out sharing screen.
Okay, sir, you may start your presentation, please.
Well, let me start this presentation with a very interesting case before we go to the nitty-gritties of what is important when we're looking at patients with a suspected PHEOs and what kind of workup has to be done for those patients. This is a 43-year-old female who was admitted to hospital in September 2019 with chief complaints of upper abdominal discomfort for 1 week. So primarily this patient had epigastric pain. The epigastric pain was, upper abdominal pain was moderate, persistent, localized in the upper part, gradual in onset, progressive, had no relation with food intake, or had no other specific factors. On examination was pretty much unremarkable, no discoloration of yellow discoloration of the eyes, no signs of jaundice. I mean, now looking at her past medical history, this patient was treated for previous 2 years with a beta blocker. Type 2 diabetes was controlled with diet and exercise. So blood pressure was kind of in a reasonable control with one medication, no other obvious symptoms, no other complaints this patient had. So the only complaint was just the mild upper abdominal discomfort. The physical exam was unremarkable. Blood pressure was 130/80 when this patient came to us. The skin sclera was non-ectatic, no hemorrhagic spots, ecchymosis, no lymph nodes were found. On abdominal examination, on physical examination, it was soft, non-tender, no organomegaly was there. So on physical exam was kind of benign on this patient. We did initial set of labs on this patient, CBC, LFTs, RFTs, electrolytes, urine complete exam, amylase, lipase, all those things, they turned out to be fine. Abdominal ultrasound was done on this patient, not knowing why this discomfort is there. We thought, let's look at the gallbladder and see how things are. On ultrasound, there was a suspicion of mass in the head of the pancreas. So the patient went for CT, and CT was performed, which showed space-occupying lesion, which was located below the head of the pancreas and was quite vascular in nature. So we thought, well, possibly this is something coming from the pancreatic tissue, kind of projecting from the lower part of the head of the pancreas. So obviously the next step in this patient was what to do on this patient. The CT did not show any adrenal mass, and the venal tissues, they seem to be fine on CT. So that was the only finding. Sent to this patient to the surgeon for their opinion. Surgeon said, you know what, let's do the carcinoembryonic antigen CA199, and those things turned out to be fine. And at some stage, it was decided between the surgeon and the patient to go for surgery and remove the mass and do the biopsy of that mass. With a pre-operative diagnosis of space-occupying lesion of the pancreas. So that was that's how the surgery, the surgical team, they proceeded with the surgery on this patient. The abdominal cavity was explored based on their notes. Irregular 5x4 centimeter mass with distinct edges was present below the pancreas, which was adjacent to abdominal aorta, inferior vena cava, and on the right side of the mesenteric vessel. Well, during the operation, when the surgeon touched the mass, the patient presented significant fluctuation of blood pressure with the maximum reading which jumped up to 200/100. So, well, that patient was fortunate enough that the mass was resected from that patient. And obviously, when there's a mass lying within the abdominal area along the chain of along the sympathetic chain, there was good intraoperative diagnosis of possible ectopic pheochromocytoma. And we will come to define what these ectopic pheochromocytomas are and what is the right word to explain them. So the purpose of presenting this case was obviously the biopsy was sent, and which showed the lesion was mainly composed of chromaffin cells. Immunohistochemical staining revealed that tumor expressed chromogranin A, NSC, and synaptophysin there. So based on this, obviously this was a pheochromocytoma, which was ectopic and which we now call paragangliomas. So the pheochromocytoma term was coined way back in 1912 based on those Greek words. Pheos means dusky, chroma means color, and cytoma means tumor. This is a dusky color tumor. So that's how it got its name. Now, what are those ectopic pheos? What are those paragangliomas, which many people confuse at times? So the catecholamine secreting tumors that arise from chromaffin cells of adrenal medulla, they are called pheochromocytoma. And the one from sympathetic ganglia, they are called paragangliomas. And sometimes you will see some enterochromaffin cell mass from the parasympathetic ganglion as well. But those parasympathetic ganglions, those masses are not functional, so usually they are not much of concern. So paraganglioma technically is a word for ectopic pheochromocytoma, which arise from the sympathetic ganglion. And it's very important to differentiate, know that what we even post-operatively, it's important to know the mass we resected is that pheochromocytoma or paraganglioma because of implications for associated neoplasm, risk of malignancy, and the genetic testing. It can vary depending on the masses, pheo or paragangliomas. They're relatively rare tumors. About 0.2% of hypertensive patients, they have pheochromocytoma. And overall, if you look at the overall incidence, 0.8 per 100,000 person years, that's the incidence there. Pheochromocytomas are more or less equal in men and women. Usually, they come within the 4th or 5th decade of life, unless one has those MEN2A or MEN2B syndrome, especially, which can come as early as in the 2nd decade of life. They can present that. But most of the pheos, they present around 4th decade of life. So suspect, confirm, and localize and resect these tumors. So in these patients, obviously, this is our goal to have a high index of suspicion anytime a patient comes with uncontrolled hypertension, comes with fluctuations of blood pressure. And this is always $1 million question: which patient we should be doing pheo workup and which patient we should not be. From clinician standpoint, it's very important, and I think there's a slide coming up that as well. So associated hypertension is curable when you remove this tumor, and other part is at least 10% of these tumors are malignant, and so that's another important reason. Even if their blood pressure is well controlled, those need to be taken out there. Those need to be removed as well. So, I mean, if you look at the clinical features, usually suggested by the history in a symptomatic patient, discovery of or sometimes you see the symptoms there. Sometimes, like in our patient, we saw an incidental mass, which was extra-adrenal, and so that is another mode of presentation. Or sometimes you have a family history in a patient, you work up that patient for familiar tumors, and that's when you find out about this disease. Now, the classic triad, we always talk about the classic triad. How do pheos present? They can present in many ways. Like the purpose of that presentation was, don't be fooled just by the presentation. Sometimes they may not present by...
we can't hear it.
Yes, I think there is some internet issue. Let's wait
Yeah,
for
I think we can't hear it.
I thought I was the only one who can't hear it.
No. The presentation is stuck at his end, at Khurshid Khan's end.
Okay. So, a fantastic presentation, I must say, so far. It was started off with a lovely clinical case and going on with it. These tumors are always there, and
Dr. Khurshid, you're on.
back. Okay, and he's muted. He's muted.
Please unmute yourself.
Sorry about that. The internet connection somehow got lost. So I'm back here now. Yeah, I think this is a slide where I got lost.
This one.
Yeah, the headache, sweating, and tachycardia usually we say is present in significant chunk of these patients. And but remember that it can present in multitude of ways. Approximately one half they have paroxysmal hypertension. Most of the rest of either primary hypertension, normally called essential hypertension, normally the blood pressure, like our patient had that. So paroxysm, what kind of, how do they present these spells in these patients? So the spells in this patient with the sensation of rush in the chest, a sense of shortness of breath. Sometimes patient describes these features that all of a sudden I feel this rush in my body, I'm short of breath. So, and then followed by a forceful heartbeat, throbbing headache, peripheral vasoconstriction, with the spell results in cold hands and feet and facial pallor. Increased sense of body heat, sweating are common symptoms that occur towards the end of the spell. So sometimes these patients present with paroxysmal spells, and it's not difficult to disregard these spells as one of the patient's anxiety attacks, panic anxiety attack. So my always suggestion has been anytime the patient comes to you with features which may suggest, may look like panic anxiety attack, we need to look more carefully into those features and just not simply label those the patients as simple panic anxiety attack, because a typical spell, the paroxysm, what we see in FEO, that can present like one of those features. So we have to be vigilant. We have to be looking for those things, and that's only we can make sure that we don't miss much cases. Let me skip this slide. So the clinical features in these patients are sustained or paroxysmal hypertension. That's the most, in 5 to 15, this is the most common sign. But 5 to 15% of the patients are with normal blood pressure, headache, 90% of symptomatic patients, generalized sweating, 60 to 70% of symptomatic patients. And then there's a pheochromocytoma crisis, which can present either with a severe hypertension or present with significant hypertension, hyperthermia, mental status change, or other organ dysfunctions in patients as well. And then there are less common symptoms. Let me skip the slide again to save some time here. And these pheochromocytoma spells, there are other diseases, multiple systemic diseases which can present like that: cardiovascular diseases, labile, essential hypertension, cardiovascular deconditioning, pulmonary edema, psychological anxiety, panic anxiety I mentioned, pharmacological withdrawal of adrenergic inhibitors, drug use, cocaine can also present like that, neurological symptoms, autonomic neuropathy can present, severe migraine headaches sometimes can present with spells like this. So when we are dealing with patients with these kind of paroxysmal spells, we need to look at these diseases, we look at the differential and go through a very extensive questioning and clinical assessment before we can label any particular diagnosis on these patients. So having talked about the clinical presentation, the location of catecholamine secreting tumors, like for any endocrine disorder, we say the location is important, but before we go to the location, remember that always the diagnostic, the biochemical testing is important before we try to locate the tumor. But this slide I just put in there to show you where most of these tumors are located when we do the workup after the initial biochemical testing. So 95% are usually in abdomen, and of these 85 to 90% are intraadrenal pheochromocytoma, 10 to 15% are extraadrenal in the sympathetic chain, which I said what we call as paragangliomas. And then there are other rare sites, that organ of Zuckerkandl, bladder wall, heart, mediastinum, carotid glomus, or jugular bodies. Those tumors can be present in some of these extra abdominal sites as well. So earlier I said it's very important to differentiate these masses because the malignancy potential varies in them. 10% of pheochromocytes coming from adrenal gland, they are malignant, but 35% of those extra-adrenal, which we call paragangliomas coming from sympathetic chain, they are malignant. So extra-adrenals, paragangliomas, they have much higher propensity to be malignant compared with the adrenal sites. There used to be rule of 10 when I was a medical student, but that rule of 10 does not apply anymore, because now we believe that extra-adrenals are about 15 to 20%. Yes, still 10% occur in children. Familial, with more genetic testing available, the number has gone up to 25, and in some studies, even it's about 30 to 35% as well. 10% can be bilateral or multiple, 10% can recur, 10% are malignant, and 10% are discovered incidentally. Again, that number has also changed with so much CAT scan, MRIs being done, so that 10% has gone up as well. Now, the few can come along, sporadic pheochromocytoma, just as an isolated finding can be there, but these are the few syndromes which have association with the pheochromocytoma. I just put them in one slide to save us some time. The MEN2A, which is medullary thyroid carcinoma, hyperparathyroidism, and pheochromocytoma. And then MEN2 is pheochromocytoma plus medullary thyroid carcinoma of the thyroid, multiple mucosal neuromas, morphonoid habitus, hyperparathyroidism, neurofibromatosis type 1, cafe au lait spots, neurofibromas, von Hippel-Lindau's disease. I mean, that's very interesting, where you see cysts and masses pretty much everywhere. Just recently, I had a patient with a pancreatic mass, with a renal mass, and with adrenal mass. That obviously was a telltale sign. Things for von Hippel-Lindau syndrome. They can have retinal angiomas along with aside from that, CNS hemangioblastomas as well. And then there are familial paragangliomas, which are we call chemodectoma, which are in the carotid body as well. So these are the associated syndromes. So anytime you diagnose a pheo, I think before we start celebrating, okay, diagnosis has been made and let's remove it, we need to look what is does it have a familial tendency, and then look for the associated features to make sure that we may come up with a full diagnosis if this is a single pheo or this is a syndrome, because the management will vary significantly, and the follow-up on in these patients will also vary significantly as well. Those were the repetitions of the same graph, same table I showed you earlier. So indications for testing. Remember, for clinicians, this is the most important slide. If there's one take-home slide for all the clinicians, all our physicians who are listening to this, I will just take a picture of this slide. So this is the most important thing. Indications for testing. Someone who has classic triad, headache, palpitation, sweating, well, that patient needs to be worked up for pheo. No matter what other causes can be causing this, that patient needs to have done that. Hyperadrenergic spells, we defined those spells earlier. So someone with those kind of spells where they feel that rush, they feel tachycardic, and then skin extremities become cold and clammy, those are hyperadrenergic spells, and those patients needed to be tested for pheos. Patients who are diagnosed with hypertension at a younger age, less than 20 years of age, that's another category. Resistant hypertension, that's another one. Or hypertension with new onset of atypical diabetes. That's very important part. Someone has had history of hypertension just recently at a relatively younger age, and patient does not have any family history of diabetes, and there is not any risk factors in that term. Patient is not obese either. This is like a regular patient. And you see this patient, you don't find, and then it's not a type 1 diabetes either. And this is the kind of atypical presentation of diabetes. So in that patient, workup has to be done. Family history of pheos, someone who has it, MEN2A, MEN2B, NF1, or von Hippel-Lindau syndrome. So those patients need to be tested for pheochromocytoma. Adrenal incidentalloma with or without hypertension. Anyone with adrenal mass, regardless what kind of mass it is, regardless what is the Hounsfield unit, what is the size, what are the associated symptoms, whether blood pressure is there or not there, should be worked up for pheochromocytoma. Someone who's undergoing surgery for some other thing, maybe for any other cause, patient undergoes surgery and during anesthesia gets that pressure response, the blood pressure shoots up suddenly during anesthesia, surgery, or even angioplasty in those patients. All those patients, they need to be worked up for pheochromocytoma. Idiopathic dilated cardiomyopathy is another point. Someone is found out to be have just cardiomyopathy. We can't find out the cause. Is idiopathic. This is for my colleague, my cardiology colleague, Professor Mohiuddin. For dilated cardiomyopathy, which is idiopathic, those patients should have workup for pheochromocytoma. So I think this is the most important part of the presentation, who should be tested. So once we, when we start testing these patients, in the first presentation, we heard about certain drugs have to be stopped. Well, and sometimes we don't stop those drugs. We want to increase our pre-test probability. But here, the goal is to honestly, as endocrinologist, my goal in these patients to make sure that I remove all the drugs which can give me false positive, wishy-washy, borderline high results. And I sit scratching my head wondering what I'm going to do about those patients now. And then it's very difficult to tell the patient, okay, you know what, you are taking one of these tricyclic antidepressants, so we need to stop that and then go back for the same test again, because in our setup, those tests are not readily available. All the labs don't do it. And secondly, there's a cost to all those things in terms of monetary costs, in terms of time. And so it's important, I think, to go through the list of these medications before you send the patient for workup. The list is quite huge. You can consult your pocket book dictionary or your iPhone, your phone, smartphone devices to find out, to look for the list of the drugs. So coming to the diagnostic workup, this is like earlier I said, any endocrine disorder, we say biochemical confirmation has to be done before we start looking for localization for that tumor. So first of all is the biochemical confirmation on these patients, and then we go for localization, and then later on we go for genetic testing, that which patient should be tested for genetic syndromes and which should not be. So coming to the initial part, well, we've been through this, which patient should be tested. So this is the very first test which I like to do on these patients. My preference usually is to go for the urinary metanephrines or metanephrines, 24-hour urinary metanephrines and metanephrines. The reason I say do this test, I prefer this test over plasma metanephrines and normetanephrines, because this one gives me a higher sensitivity, which even though plasma metanephrines also give the high sensitivity, but this test also has a high specificity as well. So 24 urine metanephrine test has 98% sensitivity and 98% specificity. It doesn't get better than that for any kind of test. So the plasma metanephrine, and the other part is sometimes 24-hour urine metanephrine and normetanephrines, labs at times do this, at times they don't do that. So under those circumstances, then I resort to plasma metanephrines and normetanephrines, where the sensitivity is pretty decent, about 98%, but specificity falls a bit, so about 85 to 89%. So here we are going to have about 10% false positive test. So again, it becomes very tricky in that regard. So preferably the urine metanephrines and normetanephrines should be done. If not available, you can resort to plasma metanephrine or metanephrine test. I have seen some clinicians doing the VMA test that really is worthless. If it comes back positive, yes, then you know you have few. Comes back negative, it doesn't mean anything. So VMA is an obsolete test, and but again, it comes down to what is available in your local setup. And I know a lot of areas in Pakistan, the other tests are not available, only VMA is. Well, under those circumstances, you can resort to that, but not a good test. Especially when it comes back negative, patient may still have fever. So if these things turn out to be positive, normally we see that the number of these, the level of these metanephrines and normetanephrines has to be significantly high, not just like at 10, 15 points, at least twice the normal range. We usually say they should be high, or close to twice the normal range should be high in these patients before we really consider them as a proper test. and other as a proper positive test for pheochromocytoma. And other part of the problem with the plasma metanephrines is the way it has to be collected. It's kind of a bit cumbersome. That patient should have indwelling cannula, means he should have Brenula in place for about 20 minutes, following an overnight fast in that patient. And the patient should be seated. Patient should be resting. Patient should be relaxed, and then you can draw the metanephrines and norepinephrine plasma levels on these patients. So after you diagnose these patients with this test, and like I said, this is the one test I use, and then I go for localization in these patients. And the localization can be done with multiple studies. We can start up with CT, but my personal preference is MRI in these patients, because I think in the next couple of slides I will show you why I prefer MRIs over CT in those patients. But you can start with, again, either CT or MRI. My personal preference is MRI, because the MRI on T2 weighted images, we see much brighter signaling from the pheochromocytoma. So it kind of reassures us that yes, patient has pheo, even though we're still going to go for the functional testing down the line. This is just the anatomical localization of the tumor we are doing at this point. So on CT, what are the high risk features on CT which suggest that patient has pheochromocytoma? If there's increased attenuation on non-enhanced CT, means there are more than 20 Hounsfield unit on CAT scan, yes, that is kind of either a malignant neoplasm there or a pheochromocytoma likely. High signal intensity on T2 weighted MRI. So that's one of my reason for liking MRI over CT, because I can see those brighter signal intensity there, and that kind of reassures me most likely this patient has pheo. Increased vascularity, these patients, that's another feature there on CT or MRI suggestive of the pheo or very functional adenomas there. Delay in contrast washout, less than 50% washout at 10 minutes, suggestive of that. Cystic and hemorrhagic changes, these are very unique to the pheochromocytomas as well. So if you see these features, yeah, they don't confirm, but they kind of increase our suspicion on the patient may have possibly has pheochromocytoma. So this is a CT scan abdomen imaging which I put in there. If you look at the arrow, this is how the pheo looks like in the suprarenal area on the adrenal gland, where these arrows are in two different views on this slide. Now, other thing is, this is a comparison I have put in together this slide, how these pheos look on CT versus an MRI. If you look to the left of the screen, picture A, this is a CT scan of an adrenal pheochromocytoma where the arrow is, but the same patient, same view, same the area viewed by MRI gives you much brighter signal intensity there. So when you see a lesion which stands out from rest of the glands with MRI, this was done T2 weighted images. These were though, and we saw that flare, we saw that signal intensity there. So this is a 90+% chance this patient does have pheochromocytoma. So that's a reason for liking MRI over CT in these patients. Once we diagnose this patient, that is okay, this patient has pheo, this patient has positive metanephrines and norepinephrines, and MRI showed a mass suggestive of pheo, we still need to look at the functional status of that pheo, because the functional status is serves two purposes. It shows you that the lesion we are dealing with is actually pheo, is producing catecholamines there. And second, it does it, sometimes there could be a second lesion as well. We don't want to operate on a patient and later on find out after closing the abdomen, 3 months down the line, find out patient has the same symptoms and end up working the same patient and find a second pheo as well on those patients, which does happen at times, even though it's rare, but it does happen. So the Mibg scintigraphy is the test which we do in these patients after we have done the CT or MRI on this patient to look for the functional status of the patient, of that mass, how much it is producing. So this is how it looks like a typical MIBG scan. If you look at where the arrow is, this thing stands out. There's more uptake of meta-iodobenzyl guanidine. This is called MIBG scan. So this is more intake of the chemical there, and this highlights. And if the mass is in the same area, the highlighted area on MIBG is in the same area, then obviously you know that this is your FEO, and you send the patient to the surgeon there as well. So the point is, what if the mass which we found out on MRI does not light up on the MIBG? Then what we do? Then of course there are other tests which can be done. Fluorodeoxyglucose PET scan is one, and now lately with the gallium DOTA PET scan being available in Pakistan, that's another test which can be done on those patients. In the past, there had been discussion about adrenal venous sampling. It's not something which got into the mainstream and is usually not done. So this is the FEO. Same patient is seen here on the. Remember, I showed you the picture earlier on that patient where MIBG scan was done. On the right, on the left of the screen, on this slide on A, you see that MIBG turned out positive in those patients. And when the same patient had PET scan done, we saw 2 lesions on PET scan with both arrows. It does not happen very often, but just put this slide in for you to realize, just to show you that PET scan with the FDG or with the DOTA PET scan, the sensitivity for picking up lesions is much higher with the PET scan compared with the MIBG scan. This is the same patient which I showed you a slide earlier on. Somehow the second scan, the PET scan was done based on family history of multiple FEOs, and it showed more than 1 lesion there. So the PET scan is always an expensive test, not readily available. So for practical purposes, I say MIBG is fairly good enough, unless you are suspecting multiple FEO and your MIBG gives you only 1 FEO, and then you say, well, this patient can have multiple based on familial pattern of the disease, or based on what the sibling had in the family. So in those cases, I think it's worth going through this hassle of doing an extra of a scanning study. But otherwise, most of the time, simple MIBG is good enough. Now, after having done that, the third part comes with genetic testing. All patients who are diagnosed with FEO should not have genetic testing done. Only a certain subgroup of patients, like patient with the paragangliomas, they should have genetic testing. In these patients, the genetic tendency for these patients is above 40%. So paraganglioma, the sibling, these patients should have genetic testing done to see if they show one of those ret oncogene mutation or SHB, A, B, C, all those succinate dehydrogenase mutations they show there. That's what usually we see with paragangliomas. If patient has bilateral adrenal pheochromocytoma, yes, obviously genetic testing has to be done. Unilateral adrenal pheo at a much younger age, like in the 20s and 30s, these are usually patients meant to be syndromes. So in these patients should be done. Patient with syndromic features, where you see multiple other neoplasm there, like I just told you earlier, this patient with the von Hippel-Lindau syndrome, von Hippel-Lindau syndrome presented with he came to me just with the CT, which was done for some abdominal pain, for totally unrelated cause, with the renal mass, with the pancreatic mass in there, and the adrenal mass. So means the syndromic features were there based on the studies, or even if you see the syndromic features based on a clinical pattern, like the marfanite habitus in those patients, neurofibromas in those patients. So all those things are suggested in those patients who should go for genetic testing. Or unilateral adrenal pheochromocytoma, where someone in the sibling also has the same pheo or paragangliomas. Those patients should go for genetic testing. So these are 5 group of patients. These are 5 indications where genetic testing is needed. Otherwise, usually it's not needed for every single case. To save time, let me skip a few slides. These are different mutations. I think I may lose my audience if I went through the details of these mutations. So let me skip that. This is summary of the same thing what I had said earlier. So no reason to go through this. We've been now after this patient is diagnosed, do not please send your patient direct to the surgeon. Yes, involve the surgeon as early as you want to, as early as can be involved, but all the things have to be done. You need to be the 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 steward of that whole situation. You need to be the captain for the whole situation, because your patient will die on the operating table. I tell you that if we do not continue seeing the patient and just send the patient over to surgeon, outcome may not be very good. Patient, yes, had surgery done, fear was removed, but yes, so much happened intraoperatively, patient died. Surgeon was he did a great job, but the pre-operatively and intraoperative part is not which surgeons are skilled with. And I would say, as endocrinologist, as clinician, you need to stay on board and take control of all these things. So medical preparation before surgery, the pre-op preparation, controlling hypertension is very important, and hypertensive crisis during surgery and tachycardia. And remember, these patients have chronically high levels of metanephrines, high levels of catecholamines in the system. These patients have significant vasoconstriction. So we need to expand their volume, because we don't want these patients to be in hypovolemic shock. Once their tumor is out, catecholamines are out of the system, the half-life is only a few minutes there. So once it's out of the system, the blood vessels expand back, and all of a sudden we find a patient who's suddenly in a hypovolemic shock there. So we expand the volume, and how we do this pre-operative management is we first of all, we need to block their alpha receptors. That's very important. We need to take all the catecholamine effect from the vascular wall and neutralize those vascular walls, block those alpha receptor with alpha receptor blockers. So alpha receptor blockers should be the first thing which these patients with the pheochromocytoma should be on, and volume expansion is initially achieved with a high sodium diet. We give them about 150 to 200 milliequivalents per liter to 200 millimoles per day of sodium, unless contraindicated for some other reason, like congestive heart failure patient has. We cannot give patient that much salt, that much fluid. In that case, we have to be very judicious, very careful not to trip the balance. That patient goes into pulmonary edema and ends up being a vent, or patient has renal insufficiency. So we have to be very careful in these patients. Luckily, most of these patients are relatively younger patients with not much comorbidities there. And phenoxybenzamine used to be really the darling for the alpha receptors, has been used for a long time. But now we have much more options in these patients with alpha blockade. I think there's a slide coming up with that as well. So once alpha blockade is achieved, then we can start off with a beta blockade to control tachycardia or control arrhythmia in these patients. But remember, we do not want unopposed beta blockade. We want alpha blockade first before we do the beta blockade in these patients. So alpha blockade, adrenergic blocking agent, is given usually 10 to 14 days pre-operatively to normalize blood pressure. Phenoxybenzamine is one of the good ones we used to use. Initial dose was 10 milligrams once or twice daily, and then dose is increased gradually over a period of days to the maximum dose, because our target blood pressure is 120/80. Other selective alpha blockers which are now available, they are preferred. Prazosin is one of those. Doxazosine is one of those. All those things can be used in our setup. These drugs, Hytrin, Cardura, which are available, that can certainly, these are alpha blockers. They can be used to blockade them, because we don't have all these agents readily available in our setup there. Now, after alpha blockade, we give these patients the beta blockade and volume expansion after volume expansion continues in parallel with alpha blockade. So on second and third day of alpha adrenergic blockade, the patients are encouraged high salt intake, about 5,000 milligram per day, which is about 5 grams of salt to counter the catecholamine-induced volume contraction. And after adequate alpha blockade has been achieved, the beta adrenergic blockade is initiated. Again, this is about 3 days, typically 2 to 3 days pre-operatively. So the goal is to keep their heart rate under good control intraoperatively and pre-operatively as well. So, and like earlier I said, beta blockade should not be done without doing, without maximizing the alpha adrenergic blockade in these patients. 10 milligram propranolol every 6 hours can be given on the first day when we plan that this is the right time to do the beta blockade. On the second day, we can convert that to a single long-acting dose. That can be done. Even if it stays at 10 milligram every 6 to 8 hours, that is fine also. So doses then increase gradually as necessary to keep the heart rate somewhere between 60 to 80 and keeping the blood pressure on 120 by 80. So once all these things are done, the patient is ready. Laparoscopic adrenalectomy by experienced endocrine surgeon for adrenopheochromocytoma is the next step. But remember, this patient should not be left alone with the surgeon. Clinician has to be there. Clinician, someone from the clinical side should be there to handle intraoperative complications which can happen in these patients. I'm running a little bit over time, so let me skip this slide and move directly to the intraoperative hypertensive crisis which can happen, or hemodynamic instability in these patients. So endotracheal intubation, manipulation of adrenal gland during surgery can release loads of catecholamines and can cause hypertensive crisis. Potential risk factors for these include plasma norepinephrine concentration, tumor size more than high baseline norepinephrine or metanephrine concentration, size more than 4 centimeter, postal blood pressure loss of more than 10 after initiating alpha blockade. So these are the patient at high risk for intraoperative hypertensive crisis. So you need to watch out for all those things. So the treatment options when these patients go in, the sodium nitroprusside is the preferred one because it's available in our setup. Phentolamine is the other one. Nicardipine, which is used quite widely in US. When I was in US, nicardipine was the to-go drug. We used to use nicardipine for all hypertensive crises intraoperatively in pheochromocytoma, but sodium nitroprusside is about 99% as good as nicardipine, so it's fine. It's available in our, so in here in Pakistan, I'm using for all these patients sodium nitroprusside intraoperatively if needed. These are the doses there. So other complications which can happen in these patients, arrhythmia is another one, lidocaine is or esmolol, depending on what kind of arrhythmia is there, and you can certainly deal with that. Post-operative hypertension, if you have, remember earlier what I said, these patients, we need to replenish their fluid. If we have replenished their fluid and salt, then usually we don't have to deal with post-operative hypertension. But yes, it can come, so be ready for that. Post-operative hypoglycemia is another one. Remember we talked about diabetes early on. Catecholamines are insulin antagonists. So once you remove all these insulin antagonists, their pancreas is kind of reset at making much higher levels of insulin for any given level of glucose in these patients. So once you remove that trigger of catecholamines, so this is that antagonism of catecholamines to insulin from the system, but the pancreas still continues for at least for the short term, for a few days, continues to make the insulin to a higher proportion than any given glucose level. So these patients can go into post-operative hypoglycemia, so be on the watch out for that as well. And when eventually it's within 24 hours or so, once catecholamine concentration is back to baseline, system resets itself and things are pretty much, so that we are out of that complication risk at that point after 24 hours time. Let me skip malignant FEOs, because all FEOs we deal as malignant, we take them out, we do the biopsy on those patients, and many times in biopsy we find out how many mitotic figures are there, and based on there's a score called the PAS score, and that will determine the malignant pheochromocytoma. So let me skip that. Other part is pheochromocytoma in pregnancy. Yeah, I can tell you I have only seen 2 patients in my career so far which I diagnosed pheochromocytoma during pregnancy, and it becomes a very difficult situation what to do for those patients. The spine position during pregnancy may allow the gravid uterus to compress the tumor, causing paradoxical spine hypertension with normal blood pressure sitting in an erect position. So these patients actually can have hypertension laying down as well. And sometimes these patients are asymptomatic until they become pregnant, and then uterus enlarges, comes out of the pelvis and starts pressing on that mass, and that's when we start seeing those fluctuation in blood pressure in these patients. So that's why it may be there, but the pregnancy, the gravid uterus, enlarged intra-abdominal, its extension to the abdominal area, pushing onto the mass, kind of unmasked the fear in those patients. Maternal and fetal mortality are high, particularly who are not diagnosed until delivery. So we cannot just say, okay, after delivery, we will work you up. Well, we know that there's a high mortality. These patients, they have to go through labor, and they can die during this labor if they have pheochromocytoma. So that needs to be addressed before that. So diagnostic workup, pretty much the same, except Mibg scan, which is not safe in pregnancy. We try not to do it, and we just rely on MRI and this flare, the signal intensity, and don't go for the nuclear scintigraphy in these patients. So the timing of surgery in these patients, I mean, this is mostly expert opinion driven. Some recommend surgery if the fetus is less than 24 gestation, and medical management if it's more than 24 weeks. So general rule is usually second trimester is a safe period when we can do this surgery on these patients. So if you diagnose this patient during first or second trimester, you operate this patient in second trimester. But if you diagnose this patient third trimester, then for a short period of time, we manage them conservatively until they are due for delivery. So at the time of delivery, we do not let these patients go through the normal vaginal delivery. We perform an elective cesarean section on those patients. So there's elective cesarean section is the mode of delivery in these patients. And at the same time, adrenalectomy also should be done when C-section is being done. So during the third trimester, simultaneously, collaboration of OBGYN is also involved here. OBGYN, surgeon, and the endocrinologist. So this the multidisciplinary approach, one working on adrenals, one working on the uterus, and the other monitoring and intraoperative management of these patients regarding hypertensive crisis or hypertensive crisis is looking into that. So that has to be done in these patients during pregnancy. So I think I will stop my presentation here, and I am very thankful to all of you for your patient learning. Thank you very much.
Thank you so much, Professor Khurshid, for the very informative lecture. And I would request for the post poll, we have post test also available. So yes. So now we can have a discussion, and can we take first question from Dr. Temia Ejaz from the audience. So Dr. Temia Ejaz, you may ask the question.
Yes.
Sir.
Walaikum salam.
Sir, Dr. Khurshid say there was a question. So he mentioned genetic testing for pheochromocytoma. यहाँ पे पाकिस्तान में in which center it is available? Like, do we send the samples abroad, US, या यहाँ पे कोई centers हैं where it is available?
Well, right now, not. I don't think there's any center of, which is doing it. All this genetic testing, especially relevant to pheochromocytoma. What I can tell you, what I usually do is there are a couple of labs, and I ask those labs to send samples abroad. And I can give you names of two labs which I use. One is the IDC Islamabad Diagnostic Lab. They usually send the samples to UK, and then there's another Excel lab which sends samples to Germany. So I have found any test now which I want to be done, I ask these labs to do it. And to my surprise, there's not much cost to those tests. Initially, I thought they would be very expensive. Just to give you an idea, just for a hypercalcemic patient, I needed 125 dihydroxycholecalciferol, which no lab in Pakistan does. So I sent the test to Germany. It cost only 5,000 rupees, which is not much considering it was sent out. A lot of handling was done, only 5,000. So all these tests can be done, but they have to be sent out.
Dr. Khurshid, since we are talking of this test, what are the implications of this test being positive, especially for people in terms of getting married later on? So you have stabilized this test and genetically it is positive. like, thalassemia, etc. So where do we stand genetically?
In this particular case, because thalassemia has much higher prevalence and incidence both. So thalassemia is a different disease altogether. But the implications of this genetic testing is that we want, for example, to give you an idea, patient who have MEN2B, and we start testing the siblings and find out the siblings also have the testing positive for the same kind of ret oncogene mutation. So in those patients, sometimes we could recommend certain preventive surgeries even before time, like medullary thyroid carcinoma, which is a very lethal CA. It can happen as early as 6 months of life in these patients. So if we found that this patient has MEN2B mutation, well, in this patient, we would want the thyroid gland to be out. But if any of the siblings also has MEN2B, we want thyroid gland to be out. And yes, then those patients need to be screened on annual basis and sometimes on every two-yearly basis for any biochemical evidence of
I understand, with certain genetic problems, there is this thing that you need to get it done. But with this one specific, what is the advantage of getting a genetic testing? That's what I'm interested in. What's the genetic advantage?
Genetic advantage in this patient?
Yeah, in this very specific. You have this thing, you get a positive result, you have a genetic basis to it. So what are you going to later on tell the family? Everyone starts getting this test done. Is that what you're going to tell them? Or they are going to say them that later on, once they have been operated on, their marriage, the next wife or the husband must be screened prior to it. So that my only thing is that what will this lead to?
Okay, now remember I showed you that slide that there are 5 group of patient population which need to have genetic testing. So those 5 patient groups need to be tested. That's one. Secondly, let me just answer the question about the marriage. Since this is a very rare disease, that's why I said that in thalassemia, yes, people need to be screened before marriage. In here, if it's not, if the screening for the fiance does not need to be done premarital in that patient for FIO for these genetic testing. So that screening is not needed. Now coming to the third part, what different we are going to do in these patients with the genetic testing. For example, if I have a patient where I found this patient has FIO, took the FIO out, and the patient is doing perfectly fine after that, then I'm not going to have a constant follow-up on that patient, on a very regular basis for certain tests. But for example, the same patient where FIO was taken out, if his ret oncogene comes back positive in that patient, so here's the difference now. Now we found out that thing is positive. Now we know that with that mutation, this patient has chances of bilateral adrenal pheochromocytomas as well. So what I'm going to do on that patient is tell the patient to get the metanephrines and metanephrine level on a yearly basis for first 3 years time, and then we can move to 2 yearly basis, and we can move to 3 yearly basis until the age of about 60 or so. That can be that is one thing. Second part of the ret oncogene, this testing is if your patient comes back positive, and again I'm going to use 2B mutation here, comes back positive, then not only I'm going to ask him to get these metanephrine level on a yearly basis for first few years, but also if it's a 2B mutation positive, I'm going to tell this patient to have thyroid surgery done also at the same time. So thyroidectomy should be done on this patient because these patients run very high risk for medullary thyroid carcinoma, and it can come at any age, very young age, as early as this has been seen 6 months after delivery, and it has been seen at much later age as well, into the 60s or so. So the future management plan is very different in these patients. And other part is if the mutation is positive, then aside from patient, we need to focus towards the family also. Now we are getting the siblings on board as well. So we are going to do this testing on the siblings also to diagnose any of those related diseases from that syndrome based on that mutation, or maybe preempt some of the surgeries before that. So that just changes the whole perspective and scenario of things this way.
Thank you so much, Professor Khurshid, for a very nice explanation. So with we are already short of time, so may I request our IT colleagues to
Or Tariq
show
Wasim
the
has raised his
post.
hand. Dr. Tariq Wasim has raised hand.
Okay.
One simple question.
Okay.
Khurshid, you already mentioned that the most common disease with which they can be connected with the panic disorder. And there is a lot of tendency in people to, with the accelerated hypertension and this panic type of disorder, to get metanephrine and all that testing done. Can we have some kind of a threshold or a cutoff that which should be subjected to? Because there is quite commonly, I mean, this at least two of the symptoms of your triad, they do very commonly present to GP or to the primary physicians.
I think,
and if I may add, I think panic attack would probably also raise your catecholamine metanephrine also.
And your pressures. Right. And your pressures.
I every other day see this panel of catecholamine being advised to these patients. So should we have some kind of a threshold?
Yeah, that's a very, very good question after this talk, that if we are saying that panic features, its spells can mimic those panic anxiety attacks. But remember, first of all, what Aziz said, we do not test these patients. We do not test these patients for catecholamines or metanephrine during panic attack. We do not test these patients during hospitalization. We want these patients to be normal with their everyday thing, and that's when we test those patients. That's one part. Second part, which the question you have asked is, again, we have to put things in clinical perspective. If people are getting, if the patient who are getting these panic attacks based on the certain triggers, anxiety or any psychosocial factors that is causing this, that needs to be looked into that. And if there's a clear trigger for that, there's no reason to work up these patients. Secondly, remember these patients, remember I said many of them, they have other features as well, like hypertension, spells for those, all those features are there. So if we find other associated features along with that, then certainly has to be done. But what if we do not find any of the associated features and there's no trigger and patient has panic anxiety attack? I think if you think about it, if you're not sure, just do it, because that's we don't want to miss those, but absolutely not every patient with a panic anxiety attack should be screened with metanephrine. Only the ones where you suspect there's something more to going on, just aside from the psychological, psychosocial situations triggering anxiety. Yes, certainly you can do that, because remember, as clinicians, we always say if you don't have a lot of negative spinal taps, that means you are missing a lot of cases of meningitis there. So certainly you will. And who knows better than you, the teaching, your lifelong teacher, Tariq Saab. So mera khayal hai ki if you feel like this patient panic anxiety is not your typical psychological panic anxiety attack, there's something more to that, by all means do it. What's
By the way, did we mention the prevalence of this disease in the population?
Yeah, we said that point in the very initial presentation. We mentioned that the incidence is very rare, about 0.2 patients we see per 1,000 person years. We see that, so it's not very common. It's relatively uncommon, but we do get our surprises. Yes.
And in your surgery, I'd just like to add one thing into it. That yes, you were very good in saying that pre and post. Those who are qualified anesthetists, somehow or the other, they do this job very well. And actually, you need to know that who's going to manage the anesthesia of this patient. And another thing that you need to know, follow it up, is because I've done some of these patients. In fact, we have a series presented in the annals under Professor Dr. Jamil, in which we had about 7 or 10 cases in which we had the series presented over there. So one thing that we started noticing was that they must be the first case to be operated that day, because their anxiety spells when they go down. So we actually always used to ask our surgeon that this patient will be your first case of the day. That's how we always got our patients operated. And the post
we can continue our discussion informally once we formally conclude the session. Let's, I think, move to the next step, please. Professor Khurshid, you are supposed to comment on these results.
Yeah, I would say what Dr. Fadi earlier said, that my message went through, that initially headache, diaphoresis, and palpitations, we got 47% saying yes. That's a classified after the presentation. 62% are saying that. So that means, yes, that's a positive thing. The message.
You're going home happier now.
I'm sorry?
You're going home happier.
Yes, absolutely. You know what? If you have audience who's listening to you, and you can put your message across to them, it's always a good feeling as a speaker. So, yeah. And coming to which, yeah, this part of the statement about hypertension patient fear is true. So all patients have, yeah, obviously, if you look at the initial slide, it's an equal distribution for the first two at least. All patients have sustained and suboptimally controlled blood pressure. That is not true. Of course, we know that. Some patients have paroxysm of hypertension. Yes, that is true. Some patients do not have hypertension, which was initially 3% said that, and B and C 45% said that. Again, I'm glad that the opinion changed after this talk, and BMC is 71%, that patients can have paroxysm of hypertension, and some patients there are some patients who do not have hypertension. So B and C is the correct answer here, the 71%, which is post-poll test. Excellent. We can go to the third question, yes. Yeah. A 46-year-old female admitted with uncontrolled hypertension, heart failure, have plasma metanephrines and normetanephrines at this much. What would you do next? So if we look at initial part, consider the response of heart failure, 9% start work for pheochromocytoma, obtain urine catecholamines, repeat plasma metanephrine as soon as possible. So in this patient, the proper answer is, let me just go and make sure that the start, obviously this patient is in the hospital admitted with heart failure and hypertension. And then metanephrine. Was there a second part of this question? I believe there was a second part.
I actually slightly changed this question. I changed the first bullet actually. Maybe that is.
Because so the purpose of this question was,
we should not proceed with the testing. That was originally in your question.
Yeah, my question was, hospitalized patients, usually we stabilize them, we get them out of the hospital, and then do workup for pheochromocytoma on those patients after the hospital. So there's some kind of change in this question. So let's skip this question and move on to the question 4. Yeah, which of the following should be ruled out before considering differential diagnosis of pheochromocytoma? So in here, hypothyroidism. Now, I mean, if you suspect hypothyroidism for some other reason, yes, can be done. Primary aldosteronism, no, not really. If you suspect hyperaldosteronism based on hypokalemia or so, yes, that can be done. And many times when there's a adrenal mass and patient has hypertension, we end up doing the work of hyperaldosteronism as well in these patients. But hypoglycemia is the one thing. When these patients, remember I said those spells, when these patients have spells and paroxysms, it's very important to check these patients' blood glucose during those paroxysmal spells. Because remember what earlier was being discussed is we should not be testing everyone with all these testing. So maybe this patient has hypoglycemia, and maybe this is a patient where we need to work insulinoma instead of pheochromocytoma on that patient. So when they have those paroxysms, their glucose needs to be to be monitored. So the right answer in here was hypoglycemia in these patients. Yes.
Okay, so it was a very nice discussion, and thank you, Professor Khurshid, for a very nice presentation. And now I would request the chair, Professor A.H. Amir, to summarize this webinar and give us take-home message.
Thank you, Anand. Can you hear me?
Yes, sir.
Yes.
Right.
Yes, sir.
Thank you. Thank you very much. A couple of things, and then we'll just quickly wrap it up. I think it is very rightly said that time flies when you're having fun. And the proof of the pudding is in eating. I think we have overshoot our time, and I still see the audience sitting. I still see the question coming. So 2 excellent talks, I must say that. And congratulations to PSIM and congratulations to both the speakers. Regarding the first talk of Freddie, I'll be very quick on that. We talked about the genetic part when he started the talk, and I said, oh God, this is going to be difficult if you're talking genetics on plasma renin activity. But very rightly so, he turned his talk to the practical part of it, that what needs to be done. So I think one question was asked by Professor Mohyuddin, very rightly so, that there has to be a difference between the resource-rich and resource-constrained country, and that has to be inculcated into our guidelines as well. And I think that need to be updated, at least the rest of the world and probably our own guideline as well. I think a take-home message from Freddie's presentation was, and so would be for Dr. Khurshid's presentation, that anything which is unusual, particularly young patient, resistant hypertension, that at least need to be screened. And I think plasma renin activity and direct renin concentrations need to be looked into. And that would make us an ideal physician. So that was regarding the first part. The second part by Professor Khurshid, I must say, his usual presentation skills, starting with a case very rightly and engaging the audience very rightly so. I think the screening part for the case concerned, I wish that there was a chromogranin screening available for these kind of cases, serum chromogranin levels, which is not available, unfortunately, in our part of the world. But what you ended up, the surgeons ended up, I'll just give a brief example that we ended up having a case referred to us from a urology who operated on a patient with hematuria, ended up having a bladder pheo, and then having a recurrent symptom. And so we found out that Mibg, that there were other tumors sitting there which were left. So surgeons have their own way of dealing with things, and we have our own. So that's very important. And what we need to look from Professor Khurshid's talk is that the familial tendency need to be looked into, and that has to be monitored and seen in the other patients as well. Finally, I would say, eyes can't see what the mind doesn't know, old saying. And I think the knowledge which is spread in these two talks was excellent. I think the proof is that till the end, I was noticing the audience was around 200, except at the end. So congratulations to PSIM for engaging the audience. It's a hats off to the PSIM for arranging such a webinar. They say that practicing medicine is an art, and I think you have presented a fine art. I thank you very much.
Thank you so much, sir, for the very wonderful and encouraging comments for our society, PSIM. And yes, PSIM is doing a lot of great jobs for this, like this. So this concludes our session, and I would like to thank all the presenters, attendees, and Edco Pharmaceutical for giving us logistic supports. And now I would like to announce the topics for the next session. So the next session's topic will be, the chairperson will be Professor Bikaram Devrajani, who is a Vice Chancellor, Eliaquat University of Medical and Health Sciences. And that session will be moderated by Professor Zainab Samad, who is Chair Department of Medicine at Afan University Hospital and a renowned cardiologist. And Dr. Omar Farooq would be the speaker who will be presenting renal artery denervation and baroreceptor modulation. And Professor Xingzhua Zhang, he will be presenting speed up and scale up hypertension control in low and middle income countries. And that session will run in the similar manner. So I would like to thank all of you for joining this wonderful session. Thank you so much.
Thank you.
Thank you, ji.
Thank you.
Allah Hafiz.
Thank you, Shahbaz साहब. शहबाज कुरैशी साहब, थैंक यू वेरी मच. आप जरा अच्छे बातचीत नहीं हो सकी.
सर हम दोनों फंसे हुए थे अपना पाकिस्तान लाइव के अंदर. आपका मैसेज आया तो मैं तो भाग के आ गया.
ज्वाइन किया, मैंने क्या चलो इनसे.
बिल्कुल पाकिस्तान लाइव में.
अच्छा,
मैं तो भाग के आ गया. फिर ये मेरे हाथ में भी उधर ही थे. अब मैं वापस जा रहा हूँ.
अब खत्म हो गई मीटिंग.
सर उसको मैं रिवाइंड मारूंगा ना पीछे, and then I'll be able to have a look at it. देखते हैं if I can do it or not. But anyway,
thank you everybody. Thank you.
Great education.
Thank you very much, Dr. Professor Aziz.
Thank you.
Inshallah, see you next Sunday. And thank you, Edco. Thank you very much.
Thank you all. Good afternoon.
Allah Hafiz.
You're welcome, sir. Thank you. Allah Hafiz. Allah Hafiz.